Okay, well, hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sakia. And today we have the pleasure of being joined by John Stone, Executive Chairman of the IgG4 Forward Foundation. He's joining us from Oslo in Norway. He's currently doing a sabbatical outside of the United States. Dr. Stone is a leading expert in rheumatology, known for his pioneering work in clinical and translational research, particularly in anti-neutrophil cytoplasmic antibody or ANCA-associated vasculitis, IgG4 related disease, and granulomatosis with polyangiitis. More of that later. Dr. Stone co-founded and directed the Vasculitis Center at Johns Hopkins University and has led landmark clinical trials, including the WGET or WEGET and RAVE trials. I love the names that people come up with for trials, which shape really the treatment landscape for these conditions. In addition to his clinical work, Dr. Stone serves, as I said, as the executive chairman of this foundation, and it's a patient advocacy group dedicated to IgG4-related disease, and we're going to discuss that. John's a huge football fan, and by that I mean soccer for our American listeners, having grown up playing the game and follows international football as well as our very own English Premier League. He's an avid cyclist, enjoys running, and he's done a few 142-mile races. And having turned 60 last year, soon after ran his first marathon in Paris, along with two very experienced runners, his children. So great pleasure to welcome Dr. John Stone to the EMJ podcast.
Jonathan, thank you very much. It's a great pleasure to be here.
You're a gent. So first of all, I have to ask you, any team in particular, and what position did you play when you were playing football, or do you still play?
Oh, well, my career was interrupted in an untimely fashion when at the age of 39, I managed to rupture my Achilles tendon. So I no longer play, but I am an avid fan of international football and of the English Premier League. I have struggled to really settle on an English Premier League team. Now, I know you're a Tottenham fan, so you'll not like my answer. But I've looked for a team where there is an American or Americans playing prominently, and unfortunately, there are a dearth of such teams in the English Premier League now. But I have, I suppose at the moment, I'm most partial to Arsenal. So I know you're not going to like that.
Oh dear.
North London derby.
Yeah, it didn't go so well the other day.
Yes,
it didn't go so well when we watched it. But we've had American players. We had the goalkeeper Casey Keller.
Oh yes, he was superb. We need him in the national team again.
Yeah, very much so. And you've got Tottenham's old manager as the new national team manager.
Yes, indeed. So we'll hope he'll do great things.
He's a good manager, and he's actually a lovely human being. I've had the privilege of meeting him. So let's dig into. Well, actually, I was going to say, if you're in London during your time off or any future time, it'd be a pleasure to take you to a game, and I'll show you what the experience of watching football with Spurs fans. You'll notice it's a bit noisier at the Tottenham Stadium than the other lot in.
It would be a pleasure, Jonathan.
So. John, I once had to operate on a patient with gastrointestinal hemorrhage. He turned out to have what was called Wegener's granulomatosis back then. I understand that diagnosing a young drummer with granulomatosis with polyangiitis, as I believe it's now called, during your residency, led you onto the path into rheumatology. Can you share how this experience taught you about the complexities of diagnosing and treating this condition?
Absolutely. So many of the things that I have been interested in my career have been driven by individual patient experiences. When I was a medicine resident, I was doing a rheumatology rotation that I had to do, and I was evaluating a 22-year-old drummer in a rock band who had difficulty hearing. And that case taught me about the complexities of rheumatic disease and having to put together the clinical findings, radiology data, pathology information, and ultimately serological data in order to make a diagnosis. So we had an odd a collection of clinical symptoms. This hearing, why should a 22-year-old, though he was a drummer in a rock band, have difficulty hearing? He also had pulmonary nodules that didn't seem to fit necessarily in my mind. He'd had a biopsy of his middle ear, which showed granulomatous inflammation, and he'd been thought to have tuberculosis. But tuberculosis in Maryland in 1992 was rather unusual. The clincher was that he had in his blood a positive antibody for an anti-nuclear cytoplasmic antibody, an ANCA, which had been only recognized in the preceding few years, and turns out to be quite specific for what the disease we called Wegener's granulomatosis, now granulomatosis with polyangiitis. And so that case really drove home for me the challenges and the beauty of making diagnoses in the rheumatic disease space. Again, having to put together information from clinical, radiological, pathology, and then serological data as well.
Can I ask, why was I should have looked this up, but why was the eponymous title discarded? Because I understand that's happened quite a lot with some other rheumatology disease.
Yes, eponyms have are quickly going by the board. In the case of Wegener's granulomatosis, it's not a pretty one. Wegener was thought to have connections with the Nazi Party during Nazi Germany. So his name was removed from the disease, probably 20 years ago now.
Yeah. Yes, I have a book on my behind me. It's one of my favorite tomes, Who Was Coudet? And I always loved asking my medical students and residents. And of course, the joke is Coudet was the Coudet catheter. Coudet was no one. It's French for elbow, because it's a bent catheter. And I loved teasing them. But there are a number of these stories also in my discipline in surgery. I didn't know that. Thank you.
Yes.
So as I mentioned in my introduction, John, you co-founded the Vasculitis Center at Johns Hopkins and led is it WGET or WGET trial?
We called it the WEGET trial.
WEGET trial,
right.
Very good. Focusing on granulomatosis with polyangiitis. What were the key findings from this trial, and how did they shape the way that this condition is managed today?
Well, I think that the results of the trial show the long arc of history and the longer-term impact that a trial can have. The most important impact of the trial was the fact that it confirmed that investigators, in this case in the United States, there were only sites in the United States performing this trial, showed that sites could collaborate together on clinical trials in vasculitis. When I was a rheumatology fellow, one of my mentors said, much to my dismay and disheartenment, that there would never be randomized clinical trials in vasculitis and in lupus. And that very esteemed mentor could not have been more wrong. And the WEGET trial was really the first to demonstrate this in vasculitis in the United States, that we could perform randomized double-blind placebo-controlled trials. The trial results were negative. It was a resoundingly negative trial. It was a wonderful hypothesis that tumor necrosis factor inhibition would increase the likelihood of achieving and maintaining remission, steroid-free remission, in granulomatosis with polyangiitis. But it was negative. It was a resoundingly negative trial. But it was a good trial. It was done very rigorously. The results were published in the New England Journal of Medicine. And the downstream effects of that were ultimately other trials, particularly the rituximab and ANCA-associated vasculitis trial, published 5 years later, which established rituximab B-cell depletion as now the standard of care for remission induction in ANCA-associated vasculitis. So if at first one doesn't succeed, try again. I think that's the lesson of WEGET.
And also to publish negative findings. It's very important to publish negative findings.
Exactly right.
Years ago, I had a patient. We'd attempted a novel surgical approach, and we'd published it. And a year later, the patient came back with a long-term problem, demonstrating that our brilliant idea was a very poor idea, actually. So we published that again. But it's always good to publish negative data. So
That's so true. I give great credit to the New England Journal of Medicine and to good and great medical editors everywhere who insist on the importance of that. It's
yeah,
really important.
stops other people going down a blind alley, really,
Right,
doesn't it?
right.
So you're on the verge of having the first approved therapy for IgG4 related disease, which is an incredible milestone. Can you tell us about the journey to this point, and what the approval of this therapy could mean for patients living with these diseases?
Thank you for that question. It has been a real privilege being associated with IgG4 related disease for 17, almost 18 years now. I saw my first patient who I knew to have IgG4 related disease right upon coming to Massachusetts General Hospital in 2007. She was a 26-year-old woman from Casablanca who had swelling under her neck. These swellings turned out to be her submandibular glands. And I had never knowingly seen anything like that. Now I know that it is a cardinal manifestation of IgG4 related disease. Long story short, I finally figured out what her diagnosis was and discovered there was a literature emerging about that disease from Japan. It had been recognized as a unique, discrete disease in 2003, and most of the literature up until that time had come from Japan. I was intrigued by the very high serum IgG4 concentrations in the disease and thought, because of my experience with rituximab and ANCA-associated vasculitis, that maybe a B-cell targeted strategy would work for IgG4 related disease. So we administered rituximab for the first time in 2008 or so, and were astonished at the plummeting of the serum IgG4 concentrations and the dramatic improvement in the major salivary gland swelling within only several weeks. So that was first published in 2010. And now here we are almost in 2025, and we have just now released the top line results of the Mitigate trial, which is a worldwide randomized double-blind placebo-controlled trial of another B-cell depletion strategy. This directed against CD19 rather than CD20, which rituximab targets. And the top-line results showed that inebilizumab greatly reduces the risk of flare over 1 year. So the primary and all three major secondary endpoints were hit. And I am hopeful that the drug will be approved by the regulatory authorities across the world in 2025.
Well, thanks for that. How common is this condition?
So, great question. I believe that I saw my first patient in 2007. We follow in our cohort at Massachusetts General Hospital. We now have 629 patients in our cohort. That's data that is accurate as of yesterday. I believe that the diagnosis is probably as common or more common than ANCA-associated vasculitis and systemic sclerosis, other diseases that have been known longer and are better known than IgG4-related disease. IgG4-related disease just got its ICD-10 code a year ago in October of 2023. So the epidemiology is not very well understood at the moment, but it is emerging quickly, and the disease is seen by practitioners of all types, including surgeons. Surgeons for a long time have been performing modified Whipple procedures on patients thought to have adenocarcinoma of the pancreas, and lo and behold, the pathology comes back inflammation. That is typically IgG4-related disease, type 1 autoimmune pancreatitis.
I have a wry smile on my face because a friend, I lived and worked in the States for many years, and A dear friend of mine called me that his sister-in-law had been thought to have an adenocarcinoma, and they'd not obtained definitive pathology. And I saw the CAT scan and I thought, it doesn't look, there's something about this that just doesn't look right. And that's exactly what she had. Absolutely fascinating. I'd never heard of it. But then again, the older I get, the longer in medicine, I realize how little I actually know about anything.
We, along those lines, we have 120 patients in our cohort with type 1 autoimmune pancreatitis, and about a tenth of them have undergone modified Whipple procedures. So,
Interesting.
still a big problem.
So your work in IgG4 related disease has been very impressive. Your discovery that rituximab leads to targeted reductions in the subclass. What advancements, what recent advancements have you seen in this area, and what future directions do you foresee for the treatment of this condition?
Well, the biggest advance, which is still hitting and is going to wash over the field for several years now, is the establishment, the proof that B cell depletion works. With conventional B cell depletion strategies, monoclonal antibodies directed against CD20 or CD19, which are B cell specific antigens. I think that there will be other approaches to targeting B cells that are likely to be effective. Cell-based therapies are now very big in the rheumatic diseases. So CAR T therapies, CAR NK therapies, and other creative approaches to programming T cells to target B cells specifically, I think inevitably will work very well in IgG4 related disease. Another important aspect of the disease that has been underappreciated and underinvestigated is the role of complement proteins in the disease. Our group recently published a paper describing the importance of complement biology in IgG4-related disease, and there are complement targeting strategies now that could also be relevant for this condition. And then maybe a third area that I think needs more exploration is the link between allergy symptoms and the disease overall. Many patients have atopic symptoms, and we don't understand the pathways that drive those things. And I think that will open up a whole new avenue of therapies as well once we understand that better, maybe parallel avenues of treatment.
Interesting. So, John, you developed the glucocorticoid toxicity index to help address the harmful effects of long-term steroid use. And you also co-founded Steritas, a company focused on reducing glucocorticoid dependence worldwide with a suite of steroid toxicity products. How do you envision the GTIs, it's called, being utilized in clinical trials and everyday practice to mitigate glucocorticoid toxicity?
So this is a huge area of concentration for me now, and has been for the last 7 or 8 years. It was my privilege to lead a group of international subspecialists in the development of the GTI, the Glucocorticoid Toxicity Index, which was developed as a clinical outcome assessment for use in clinical trials. And it has been used in clinical trials. It has been used, in fact, in almost 30 different diseases in either clinical trials or studies of other kinds. It has been very important in studies of ANCA-associated vasculitis and in giant cell arteritis, for example, and I think will contribute to the regulatory approval of drugs in that space. So it's used in clinical trials. An abridged version of the GTI, known as the GTI-MD, GTI metabolic domains, can be used in large data sets to try to chronicle the burden of steroid toxicity in a given disease. For example, sarcoidosis or any sort of inflammatory disease in which steroids are important. And we are also developing a longitudinal experience using the GTIMD in clinical practice because it's an abridged version. It is possible, even for busy clinicians, to use the instrument. So steroids have been such a cornerstone of so many of the diseases during our careers, Jonathan, and we are beginning to see that move out now as we have therapies that work and can replace steroids. It's important to be able to measure steroid toxicity and reduce steroid toxicity.
Yeah, very much so. So, through the foundation, the IgG4 Forward Foundation, you've been working to improve education and support for patients with IgG4 related disease. Can you tell us something about the foundation's key objectives and how you hope it'll impact patient care and awareness? And is it active globally, or is it just in the United States?
Thank you. So this has been an effort that has been going on for almost a year now. The IgG Forward Foundation had its launch in November at the time of the American College of Rheumatology in 2023. So we've really only been in existence about 9 months. But we have made tremendous progress over that time. The founding of the foundation coincides with a great era of knowledge in the disease, with the demonstration of the efficacy of B cell depletion. So our three major objectives are: number one, education. When I saw my first patient, I had no idea about the existence of this disease. And you can imagine how difficult it is for patients who have this disease, who've been on a journey of diagnosis that has often been years, and they are not able to find reliable information about their diagnoses. So education is the big thing. Spreading of awareness of the disease and linking patients to knowledgeable clinicians, and then finally helping to foster research in the condition is the third thing.
Yeah. I am involved in another podcast for patients, and mentioned during the course of one of it's a conversation between two friends who are doctors. If you think car talk with medicine, the old NPR show, which I loved, and we mentioned Ehlers-Danlos syndrome en passant. And I think we had 70,000 people reaching out to us. Like everyone with Ehlers-Danlos, I think in Britain and America, was reaching out because they were so happy that someone had paid a little bit of attention to the condition that they live with on a daily basis. So maybe we'll have to talk about IgG4 related
I would
disease.
love to have a longer conversation about that. It's such a privilege to be able to make a diagnosis and tell a patient that, yes, we know what is wrong with you finally, and
Yeah,
even better, we can treat it.
yeah,
It is an incredible privilege to be able to do that.
yeah, it is. And I must admit, every time I hear people talk about burnout in medicine, I always think, I'm sorry, what? We're the luckiest people on the planet doing
Right.
what we get to do and help people. So you wrote an edited a textbook called "A Clinician's Pearls and Myths in Rheumatology," published by Springer, who I did a lot of work with over the years. Can you give us one of each, a pearl and a myth?
Absolutely. So I'm going to have to give you two pearls if I can. They're
Great.
quick. The two pearls are both pertain to granulomatosis with polyangiitis. Patients with GPA can develop nodules on the elbows. These look very much like rheumatoid nodules because they occur in exactly the same place, but they're not rheumatoid nodules. They're what dermatologists call cutaneous extravascular necrotizing granulomata. And these nodules, which patients are typically unaware of, can be case breakers. They can put together the patient's diverse symptoms, the upper respiratory tract symptoms, the pulmonary nodules, the glomerulonephritis, even without having the ANCA test, if you find these nodules, that can really clue you into the proper diagnosis. So the second pearl also pertains to GPA, granulomatosis with polyangiitis, and this explains why some patients with GPA develop a facial droop. Again, it gets back to the very common inflammation in the middle ear, like my 22-year-old drummer in the rock band had. It turns out that the seventh cranial nerve courses through the middle ear. So that granulomatous inflammation, which causes otitis media, can compress the seventh cranial nerve and lead to a facial droop. So that's the second little pearl that I sometimes enjoy talking with residents about in clinic. Now, the myth is that glucocorticoids cure rheumatic diseases. I grew up in the era, and it's still unfortunately too true, that steroids are the cornerstone of therapy for our diseases. But over the course of my career, it's become very clear that these drugs, wonderful and important as they are when you have nothing else, don't cure our diseases. They suppress them. As long as patients are on doses that are unfortunately too high and lead to toxicity. But even when they seem to be under control, we're more sophisticated now in gauging disease activity, and we're finding that there is still ongoing disease activity. So the glucocorticoids as a cure for rheumatic disease are, I think, the greatest myth.
Oh, fascinating. I love that kind of stuff. So to wrap things up, John, if you had 3 wishes for the future of rheumatology, and there's a lot that has happened in your specialty over the years. And I remember when I graduated, it was glucocorticoids and methotrexate, I guess. Yeah, you've got so many more diseases. What if you had 3 wishes? What might they be?
So the first one relates to an area of rheumatic disease where we have not made much progress. And this is in the area of systemic sclerosis. So my mother had systemic sclerosis. She had limited systemic sclerosis, and she died when I was a medical intern of complications of systemic sclerosis. And now, more than 30 years later, we still haven't achieved a therapy that really alters the underlying pathophysiology of systemic sclerosis, whether it's diffuse disease or limited disease. So I would love to see during my career or soon thereafter an important advance in systemic sclerosis that really alters the underlying therapy. The second wish for rheumatic disease would be that there is a more thorough knowledge and a greater appreciation of immunology by physicians of every stripe, because it's now clear that so many different diseases relate to immunological disturbances, and a more sophisticated understanding of this by physicians and practitioners in general, I think, would lead to much better outcomes for patients. And then finally, I have to say that for patients, you've alluded to the dramatic advances in therapies that we've made in so many of our conditions. But access to these therapies continues to be a struggle for many patients in many places. So broader access to these wonderful new therapies would be my third wish for the field.
Yeah, we're going to have to do something in so many areas of healthcare. You can have all these amazing advances, but if only a very few people can access them because they're too expensive, and countries are going to have to make decisions about where they expend resources because healthcare has become so expensive everywhere.
Yeah, I couldn't agree more.
So sadly, that's all we've got time for today. I'd like to thank you, Dr. John Stone, for being with us today. Real pleasure to chat with you, and I hope you have an amazing time on the remainder of your sabbatical.
Thank you, Jonathan. It's been a real pleasure. Thank you for the invitation to join you today.
And like I say, come watch some football together.
All right.
It'd be a cultural experience. So, folks, please consider subscribing on Spotify or Apple Podcasts so that you never miss an episode. Like us on social media, tell your friends, you know the drill, and check out the archives. There's several hundred episodes there, so lots to dig into. And I don't know about you, but I love going to bed a little bit less dumb. And finally, please join us next week for another interesting episode of the EMJ podcast. Until then, I'm your host, Dr. Jonathan Sakia. Please, everyone, stay safe, stay well, stay curious. Bye for now.